I would like to thank Professor Harikrishnan Iyer for organizing this fifth Global Wound Conference in association with DFood International and many other organizations. So, what I'm going to talk to you in the next 12 minutes is on saving the limbs in people with diabetic foot infection, our experience in India. And let me share the slides. I have nothing to disclose as conflict of interest. People in India and many of the developing world have a poor knowledge about foot care, particularly those with a lower level of education and socioeconomic strata. This is a publication which we did 24 years ago. And sociocultural practices, especially among the developing world, among the people in the developing world, is responsible for most of the foot infections that we see in our day-to-day practice. Our colleagues from King's College London, Ali Foster, the late Ali Foster, and Mike Edmonds, who retired recently, gave us this algorithm of normal foot, high risk feet, ulcerated feet, infected feet, necrotic feet where there's a gangrene, and unsalvageable foot. So the first two stages, physicians are involved because we are dealing with people who have normal sensation and people who have normal blood supply. The high risk foot is when people have loss of protective sensation or they have peripheral artery disease, less of blood supply. The stage 3 and stage 4, we need the surgeons to come into the picture. They have ulcerated foot and infected foot. The most important is the stage 1 and stage 2. How do we make an early diagnosis of diabetic foot infection? And this is very, very important from the standpoint of the developing world. The Ipswich touch test by Jerry Raymond and his colleagues from Ipswich was a very simple method of evaluating for loss of protective sensation by just touching the first, third, and the fifth toes of both the feet. And if you can't feel in two areas of each foot, then you are supposed to have a loss of protective sensation. So this is a very simple test which we can do. The monofilament testing for testing the large nerve fibers is using the 10 gram monofilament and testing it in 3 areas in each feet again. And one of the 3 areas will be a sham testing. The other two will be actual testing. So this is for testing the large nerve fibers. The vibration perception threshold, as defined by our colleagues from Manchester, Professor Andrew Bolton and colleagues, have found that if you have a if you're able to feel the vibration at 25 volts or higher, you have a higher chance of getting foot ulcer. The neuropathy disability score again was developed by Carolyn Abbott and by Professor Andrew Bolton from Manchester. And it's a very simple method of diagnosing loss of protective sensation in the feet by testing with a 128 Hz tuning fork, testing the temperature, pinprick, and the ankle jerk by using a knee hammer. And if you can't elicit the ankle reflex, you give 2 points. And if you can't feel the pinprick or the temperature on the 128 Hz tuning fork, you give 1 point each. And what they found was if you have a score of more than 6, then you're getting a chance of getting an ulcer is more than people who have a score of less than 6. This is a prospective study done in Manchester and was shown to be predictive of ulceration. Let us not forget that the blood circulation has to be tested, and every physician should have a handheld Doppler test where we look at the can look at the sound in the dorsal aspiratus artery and the posterior tibial artery. And when the sound is sort of triphasic, the flow is okay. The flow is monophasic, then you have peripheral artery disease. Diabetic neuropathy, this is a article which I wrote along with my colleagues, neurology colleagues from UK and USA. And we showed that neuropathy, we wrote this in Nature Reviews, and neuropathy is very common and is one of the commonest causes of diabetic foot ulceration all over the world. There is demyelination and there is axonal degeneration, which happens. You can see here the demyelination and also the axonal degeneration, which occurs in people with diabetes. Now, once you have a wound, then the focus shifts to a multidisciplinary approach. And in the last 5 to 8 minutes, I'll talk to you on what is this multidisciplinary approach. If you have an ulcer, if you have a necrotic lesion, if you have an ulcerated, infected lesion, then you need a mechanical control, wound control, microbiological control, vascular control, metabolic control, and education control. These are also it's a simple algorithm given by our colleagues in King's College, London. Mechanical control is where you offload the pressure from that area where the ulcer is. Wound control is applying a good dressing, wound dressing, which the patient finds it convenient to use at home. He doesn't have to come to the hospital every day to change the dressing. Microbiological control is done when the patient is in the hospital. You take a swab from the operation theater and find out which is the bugs or organisms which are growing inside the wound. Vascular control, as I showed you, the Doppler test, handheld Doppler, or by palpation of the dorsalis pedis or the posterior tibial pulse. If you can't feel this pulsation, then you have to refer to a vascular surgeon or an interventional radiologist. Metabolic control, many of the people have sepsis, infection, and the blood sugar goes up. So you have to institute a basal bolus insulin regimen in most of the cases, unless their blood sugars are normal with basal, not with oral drugs and so on. Education control is you have to educate the patient not to walk, not to put pressure on the ulcer area, and so on. Now, talking about multidisciplinary approach, you can save many a limb if you have multidisciplinary approach. This is an example of a patient who came to us with an infected ankle joint, infected wound in the ankle joint area with necrotizing fasciitis. So what you do is the one of the surgeons, podiatric surgeon or plastic surgeon or a general surgeon in India does a wound debridement and cleans the wound, right? Secondly, this patient had peripheral artery disease, no blood flow in that area. So the vascular surgeon is consulted and he does, for this critical limb ischemia, he does a bypass surgery in the restoring the blood supply to the ulcerated area. Today, with developments in the interventional radiology, it has become possible to put a stent or a balloon into the arteries. The ankle joint becomes unstable because of all these procedures. So you put an external fixator and fix the ankle joint. So you need an orthopedic surgeon. So you need a vascular surgeon, podiatric surgeon, and now we have called in a orthopedic surgeon. And finally, as you can see here, we've done a skin grafting of the wound, and that requires a plastic surgeon again. So it is a multidisciplinary approach which will help in saving limbs. That's the main message I would like to give from my talk today. Offloading is very important. People tend to use any type of footwear. Like you see, this is in India. People have people love these Hawaii chappals because it's so convenient to use. But you can see that it produces lesions in the foot by using a Hawaii chappal. A Charcot foot with an ulcer is a difficult problem to treat, and you need special offloading devices to offload such ulcers uh, on top of a Charcot feet. For Charcot foot, we have developed a Crow Charcot restrained orthotic walker, which costs only over 2,000 Indian rupees. And we developed this Crow, which is applied, and the patient walks on it and walks using this, and it heals. So this is a Crow device. We have set up a footwear manufacturing unit in our hospital in Chennai, where we make these footwear offloading devices to people. We also make footwear for people who have loss of protective sensation, who have not yet ulcerated, or those people who have ulcerated and it has healed. So these are some of the models which we use. It's called a designer diabetic footwear. These are for people who have loss of protective sensation, but have not yet ulcerated, or ulcerated but healed. They have an healed ulcer. So the characteristics of a good footwear should be there should be a counter. There should be a counter. Don't give a footwear without counter. The insole should be soft. There should be nothing in the upper which will hurt the insensate feet. And you need to expand the footwear, the upper, by using a Velcro strap. So these are the characteristics, and the toe box should be wide. So these are the characteristics of a good footwear. These footwear are available for sale through Amazon India, where you go to the Amazon India page and you search text box, you type MB Diabetes Healthcare, and it will take you to the product page. And this is a number 99628 55535. If you have any problem, you can call this number. The IWGDF guideline, I cannot end this talk without referring to the IWGDF guideline, which comes every 4 years. And in 2023, in May, the IWGDF guidelines were released. I was fortunate to be a part of the wound healing and offloading guidelines. And you can check out the IWGDF guidelines.org website and read about all the topics about IWGDF, what the IWGDF writes. My last message is people who have loss of protective sensation, who have peripheral artery disease, must examine the feet every day. You see this person examining the plantar aspect of the foot with a mirror. If it's a magnifying glass, it's still better. And it can detect minor lesions under the foot and corrective action can be taken. I'd like to thank you for your attention. Once again, thank Professor Harikrishnan Nair for organizing this wonderful meeting today, and of which DFoot International is a part of, along with other organizations. Thank you for your attention.